We present a video of superficial temporal artery and submillimetric middle cerebral artery bypass with encephalodurosynangiosis for pediatric Moyamoya disease. Our patient, 10-year-old female, admitted with history of transient weakness of left upper limb followed by lower limb 2 years back, which improved over 2 months. There was history of similar complaints after 6 months of first episode. During admission, patient had no complaints and no neurological deficits on examination. On right and left ICA injection in digital subtraction angiography showing puff of smoke, appearance of Moyamoya vessels, progressive occlusion of ICA, non-visualization of ACA and MCA vessels, and absence of ECA collaterals in right ECA injection suggestive of Suzuki grade 4 disease. Arterial spin labeling study suggestive of decreased perfusion in right temporoparietal region. Surgical strategy consists of surgery on symptomatic side first, harvesting STA through linear incision along the artery, right frontotemporal craniotomy, preparation of donor and recipient vessels, end to side STM4 anastomosis, dural synangiosis, and then closure. Patient was positioned supine with right shoulder support and head on Mayfield clamp with 90-degree rotation. Incision marking was done using 26 gauge needle under Doppler guidance. Incision started proximally anterior to pinna. Superficial sharp dissection is being done to expose superficial temporal artery. Incision and superficial sharp dissection is extended along the length of the STA to expose it of about 10 centimeter length. STA is dissected with loose tissue cuff on either sides to mobilize STA throughout its exposed length. STA is also dissected off from loose areolar tissue underneath the artery. Any bigger branch is cauterized after applying clip. STA is being stained using methylene blue dye for identification purpose. Skin flap is extended towards the frontal and parietal regions as shown in schematic diagram. And frontotemporal craniotomy was done. Dura is opened in cruciate fashion. Sharp arachnoid dissection is started in search of good recipient M4 vessel. Diameter of this M4 vessel is approximately 0.7 mm and chosen as recipient vessel. Small cortical branches are coagulated to free this artery for the purpose of passing background sheet underneath and to prevent influx of blood in the lumen during the anastomosis. Perivascular sheath is sharply dissected off the STA to free the part of the STA at adequate length to prepare it for anastomosis. STA is clamped proximally using temporary clip and then sharply cut in oblique fashion after clamping it distally too. After that, STA lumen was irrigated using heparinized saline. Staining is done using methylene blue dye at this oblique transaction and then perivascular tissue is completely disconnected to mobilize the STA towards the recipient M4 MCA. Size of oblique opening of the donor STA is judged for arteriotomy of M4 MCA. After insertion of black background beneath the MCA, it is clamped distally followed by proximally using temporary clips. Two adventitial 10-0 ethylene sutures are taken at the planned arteriotomy site. Kindly note that one thread of each suture is kept long. M4 MCA arteriotomy is started from either side holding that long sutures. We would like to convey that this technique of arteriotomy should be tried after adequate practice in laboratory. This flap of arteriotomy is retracted using 11-0 ethylone suture and hitched to nearby pia. This retraction should not be tight. Donor and recipients are matched just before starting anastomosis. Donor vessel end is again stained with dye. Anastomosis is started with 10-0 ethylene suture at heel and followed by at toe. Only two throw reef knots are taken each time. Third knot is not required as there is increase in weight of the knot and inflammation. This we have proven with multiple animal and human studies. Intermittent suturing is started on side opposite to the arteriotomy flap and opposite wall involvement by the suture is confirmed by turning STA as shown. Other sutures on this side are completed in similar fashion. Only two reef knots are taken each time. STA is now turned to other side to expose arteriotomy flap side. Surgeon need to change the position of the chair with respect to the head before starting other side suturing. Two sutures are taken first on the either side of the flap. We can observe that black background is not hindering the view of black suture material. Moreover, it provides best possible contrast against unstained MCA. Arteriotomy flap is cut partially to facilitate one knot. Then flap excised completely and sent for histopathology reporting for research purpose. Remaining stitches on this side are completed in intermittent fashion, keeping the sutures fast and tying knots later. Papaver soaked cotton is kept on the anastomosis for 1 minute. Distal MCA temporary clip is released first and gush of the blood noted traveling towards the STA which is clamped proximally. Then proximal MCA temporary clip is released. After releasing STA temporary clip, flow is confirmed on ICG injection. Flow is noted even from the proximally exposed STA segment. Direction of flow again confirmed by using Doppler. Dural synangiosis is performed by inverting dura on the cortical surface. Immediate postoperatively, patient had no fresh deficits, no further ischemic events. The subgaleal drain was removed on the postoperative day 3 and patient was discharged on postoperative day 5. Postoperative CT scan suggestive of no hematoma and no infarct. Wound was healthy at the time of discharge. MR angiography after 3 months showing patent anastomotic site shown by yellow arrow and red arrow showing resolving Moyamoya vessels. How our technique is different. Keeping dissected STA intact during craniotomy. Use of black background during anastomosis. Two stitches over adventitia of M4 MCA just before arteriotomy. Retraction of arteriotomy flap using 11-0 ethylone suture. No dye on the MCA during suturing. Looking for other side wall of STA and MCA during one-sided suturing. No use of muscle for synangiosis. These are our references. We would like to convey that most of the instruments used for this anastomosis are Indian made. Thank you.